Let's do neuro wrongs on June 29th. We've got 15 of them here, starting with a paraneoplastic syndrome that happened in a 60-year-old woman. She got brought to the office because she had 6 weeks history, 6 weeks of progressive unsteadiness and coordination in slurred speech. And over the last 6 months, she had a non-productive cough, fatigue, and an unintentional weight loss. We locked in on the fact that the time course of her deficits was pretty fast. And the thing that looked familiar that happens fast is Creutzfeldt-Jakob. There was this weird thing about the MRI having multiple T2 hyperintensities in both cerebral hemispheres and mild cerebellar atrophy with enhancement of the cerebellar folia, which just sounded either Creutzfeldt-Jakob either sounded like maybe some weird prion infiltrations, or maybe this other thing was called multi-system atrophy, and maybe multi-system atrophy had something to do with that. As it happens, multi-system atrophy would have been orthostatic hypotension, dry mouth, anhidrosis, urinary incontinence, and erectile dysfunction, none of which does this patient have. What she does have is a smoking history over the last 40 years and now bilateral horizontal nystagmus. And they want you to go with paraneoplastic syndrome being the reason why she has progressive unsteadiness and coordination and slurred speech. Not terribly unreasonable. I think a good part of this is that there's not really anything that's more reasonable than this. It doesn't fit multi-system atrophy. I don't know what Miller-Fisher is. Apparently Miller-Fisher is a subset of GBS, so it's not really GBS. It doesn't fit Wernicke's. You could maybe, it's almost like a lateral palsy. They say they have bilateral horizontal nystagmus, but suffice it to say, paraneoplastic syndrome in a patient who had been smoking 15 cigarettes daily for the last 40 years is not terribly unreasonable. You can couple that with her 15-pound unintentional weight loss, and you can see how they're kind of giving a little bit of cancer hints, and we just didn't necessarily lock onto it at the time. Next one is cervical stenosis. Just worth noting that cervical stenosis doesn't come up nearly as often as lumbar spinal stenosis has come up. And the presentation for cervical stenosis is kind of like a lot different. Cervical stenosis leads to an impingement on specific nerve roots, leading to motor and sensory symptoms concordant to the distribution of a specific dermatome and myotome. So, like, this lady has weird walking, burning, tingling sensations. She had difficulty walking and then burning and tingling sensation in both hands, which to me was misleading because it's almost trying to say that the deficit is like related to her lower extremities because she's having difficulty walking. But to their defense, it has 4+ deep tendon reflexes in the lower extremity and 1+ deep tendon reflex in the upper extremity, with a Babinski being present bilaterally. So they're telling you that it's upper motor neuron. Even then, that's just something that you kind of just have to keep in mind. Another option that looked juicy to us at the time was parasagittal meningioma, which could present with headache, seizure, focal neurologic deficits such as lower extremity weakness wouldn't be expected. I'm sorry, deficits such as lower extremity weakness and numbness associated with local mass effect. This is interesting. They're basically trying to tell me that the reason why it wasn't parasagittal meningioma is because the lower extremity muscle strength was 4 out of 5 distally, 5 out of 5 proximally, with muscle tone being increased. So, sort of tough. I think this is, even when you read the explanation, it doesn't seem super duper clear, but it's a 72-year-old man who had a 2-month history, difficulty walking, burning and tingling sensation, and they want cervical stenosis for that. So just have to keep that in mind. Next is the alternate treatment for hepatic encephalopathy is rifaximin. Sure, 8 times out of 10, they're going to give you the lactulose. If they want to be fun, like they do in this specific set of neuro questions, they're going to go ahead and give you the beta subunit of DNA-dependent RNA polymerase, which inhibits bacterial synthesis and is itself bactericidal. So that'd be rifaximin, the gut selective antibiotic. Then we flip the very next one we got wrong also. Somebody with trigeminal neuralgia. One of the reflexes you're going to want to test on that person is going to be corneal. They're just saying that trigeminal neuralgia is neuropathic pain disorder, which presents with severe shooting or burning pain in the innervated regions of the sensory branches of the trigeminal nerve. And it was worth noting that the corneal reflex is lost in patients that have trigeminal neuralgia. It wasn't necessarily a crazy presentation. She was 18 hours pain, electric jolt that turns on and off every minute. While she was brushing her teeth, she had very bad pain. Wasn't super well hidden that this was trigeminal neuralgia, but they just decided to see if you can link corneal reflex to trigeminal neuralgia. Here we have psychomotor slowing as the right answer in an 82-year-old woman. These neuro questions and this neuro-specific bank do kind of like to play on this "it was just normal" basically thing. I think that that's what they're saying. Psychomotor slowing is a normal aging. Um, and so losing things like attention span, executive functioning, and problem solving after 7 years old is not really a big deal to them. Of note, having an absent Achilles reflex, arcus senilis, decreased vision and hearing, decreased immune response, and increased suicide rate. I don't know if I would necessarily want to call that normal, but those are normal aging findings. It's interesting. I have that right there. Increased suicide rate. Wow. Just because it's just true. I don't know if that necessarily means it needs to be normal. Here we have a 3-month-old boy who turns into floppy baby. And so they want you to do a stool toxin assay to diagnose the botulism. There was a whole bunch of weird stuff going on in this question. And as it happens, their explanation is that it was possibly given in the form of honey to a from the parent to the child. And that's a nowhere in this story. There's a whole bunch of other weird stuff about switching their food and dad working in soil. But at the end of the day, the pupils were 5 mm, gag reflex got decreased, and they had muscle tone being decreased. So a 3-month-old going kind of floppy, it's worth doing a stool toxin assay. A stool toxin assay in order to find the botulism. Here we have a 9-year-old girl with an open fracture that they still call compartment syndrome. This was news to me. I would have thought if the fracture was open, it would be difficult to do compartment syndrome. Almost just from first principle in the sense that the bone going through the skin is the fasciotomy. Like you're doing a fasciotomy on yourself. So worth noting that you can definitely still get compartment syndrome. I guess maybe it just doesn't open it up enough. I'm not sure how this would exactly happen, but she was a 9-year-old. She had a open tibial fracture, and she still got compartment syndrome. She had weakness at toe flexion, severe pain, and passive extension of the toes, and plantar hyperesthesia. Those are all compartment syndrome findings, absolutely, but just a little bit bizarre to say that it was an open fracture. I don't know if I had seen that before. Next is a carotid cavernous fistula. They went carotid on this one a bunch of times. We got most of them right. This one was a motor vehicle collision that happened a week ago. If you remember it from the other questions, like a lot of the times there's these weird focal deficits, weird problems that happen that you wait a while and it ends up being subdural hematoma. But this patient was having severe pain of the left eye and double vision and exophthalmos, which I don't know if I've seen those so much with subdural hematoma. What's more is this person has a bruit over their left orbit, which then leads you to say, oh, wow, could this be arteriovenous malformation? And in reality, they just wanted carotid cavernous fistula because they were saying that it could be like a low flow fistula, and that if you were going to diagnose it, you would do a CT or MR angiogram, and then the first line treatment would be an endovascular intervention with embolization or stenting. Fair. Here we have a 47-year-old who came in 45 minutes after sudden onset of a severe headache. That's really what they wanted. I mean, they wanted you to just kind of like lock on to this first sentence where it's saying sudden severe headache. Um, she had had 25 year history of headaches before this, so I think that immediately started to distract me and say, well, maybe this is some sort of chronic issue. But really, sudden severe onset headache, severe headache. Uh, you always have to keep subarachnoid hemorrhage, and they're going to use ruptured saccular aneurysm here as the like pseudonym for that. But a vertebro-basilar migraine, which is what you pick, it would also have diplopia, dysarthria, nausea, or vomiting. Um, so in that way, it's similar, but they're just saying the most common cause of non-traumatic subarachnoid hemorrhage is a ruptured intracerebral aneurysm, and subarachnoid hemorrhages present with acute severe headache, nystagmus, and can lead to altered mental status, stupor, and coma. So it's actually a decent amount of like blurring the line here in what is saccular aneurysm, what is a subarachnoid hemorrhage. They like to throw some weird risk factors like Ehlers-Danlos and polycystic kidney disease, of which she does not have. So she just has these weird headaches once or twice a year associated with nausea, vomiting. She has hypertension that's treated with enalapril, and she has a blood pressure 154/96 in this vignette. So, she has pain when the neck's flexed. I guess maybe is that a vertebro-basilar migraine finding? Maybe not. Her muscle tone is increased in the right upper and lower extremity. Again, is that a vertebro-basilar migraine finding? Probably not. It's probably more of a ruptured saccular aneurysm as age. Next is cytarabine can apparently cause, this is absolutely news to me, but cytarabine can apparently cause acute cerebellar syndrome. This is a 27-year-old, bizarrely short, 4'7", like, that's crazy short, but fine. As it happens, cytarabine can cause a loss of Purkinje cells in the cerebellum. In this particular instance, she has nystagmus, ataxic eye movements, and marked ataxia in all of her extremities. She's unable to maintain her balance sitting or standing unsupported. She's somnolent with an irregular speech rate and volume. And you're supposed to just know that cytarabine can be toxic to the Purkinje cells in the cerebellum. Interesting. Here's a blast from the past, right? So what could you do if you wanted to go totally like Project Mayhem on somebody with Parkinson's disease? You could just, why not? I mean, it's a problem with the globus pallidus. Why not just destroy it, right? That's fine. They've been trying some other stuff. Obviously it wasn't a first line option, but they're like, oh yeah, well, she's been trying stuff and she has constant writhing movements of the mouth, neck, and limbs. She's still having a problem with taking small steps and small arm swing. We've already tried carbidopa, levodopa, and ropinirole. So, I don't know. Medicine's not working. What could we do? What would be a surgery for this? That's a good point. I mean, it's not like they're saying it's a great plan. They're just saying, like, if you were going to do a surgery to help somebody with Parkinson's, what would you do? It'd be pallidotomy. Well, I mean, fair, just bizarre. Next is another normal finding in an older person. This one was particularly tough, but again, the Achilles tendon is absent, and they really just loved you knowing that Achilles tendon being gone in an elderly person is just totally fine. I will say in the past they've been using 70 as their cutoff. When they say the explanation, they'll be like, well, 70 and older is what they're calling elderly, and this patient was 67. We want to know that the abducens nerve exits the brainstem ventrally at the pontomedullary junction and innervates the lateral rectus of the eye. Any abducens nerve palsy may result from microvascular ischemia and present with binocular horizontal diplopia and ipsilateral abduction, deficits of the affected eye. And I guess that's just fine. I mean, they're just saying, like, this is abducens nerve palsy, and it's not a big deal. Treatment involves systemic workup to see if there's any vasculopathic risk factors and patching to reduce the diplopia. But in terms of if there's anything more to it, like, it's mostly she's just an old lady who now has an abducens nerve palsy. So she even has pain behind her right eye and mild nausea, and you're supposed to just tell her to put a patch on her eye. So I don't see you getting like a great Yelp review after that one. Diagnosis of brain death can be determined by the presence of three factors: absence of brainstem reflexes, persistent coma, and lack of spontaneous respirations. So we'll just repeat that as brainstem reflexes, persistent coma, and lack of spontaneous respirations. So just think weekend at Bernie's on that one. Here we have bilateral knee pain. It had started in one knee, went to the other. Range of motion is full in one knee. It's limited in the other one by pain with moderate joint effusion. 37-year-old dude. It's been going on for 3 weeks. They want Lyme arthritis here. It seems that they are confident to tell you that it's not gonococcal arthritis because there was no fever, malaise, or migratory polyarthritis or oligoarthritis. There was no hints that they had been exposed to ticks at any point. They don't write anything about where they are, if they've been on any trips. There's nothing. There's nothing that I can see from this 3 or 4 sentence question that's giving me reason to believe that he's been exposed. You just have to get there on your own accord. Whereas they actually mislead you and say he's been sexually active with multiple people and uses countenance inconsistently. So you would be more likely to pick gonococcal arthritis if you're just going off from what you know in the vignette. But his blood pressure is the only thing that's a little bit out of whack in terms of vitals. His temperature is fine. And so for this particular patient, they want you to just see, and that's actually even more hot garbage because they're saying 6 weeks ago he did have a fever, malaise, and a 5 centimeter rash. So they want you to read. They actually want you to read into the fact that the 5 centimeter rash with central clearing was erythema multiforme, and that was what you should have locked onto. Um, Again, fine. I mean, you have to read through these questions sometimes and see what their weird hint was. But in this particular instance, they hid the Lyme disease by saying it was a 5 centimeter rash with central clearing on the chest. That's all we got.